Good morning, everyone. I hope you can hear me okay. We're getting a bit of a battering in Scotland just now with some nice strong winds and rain. Okay, we're just waiting a wee bit longer and see how many more people can join us. People get set up. Okay, while we're waiting, I'll just run through some housekeeping slides with you all before we jump on to the presentation for today. So this webinar is part of a series of webinars that we've been running over the past couple of years as part of our Early Intervention in Psychosis programme run by Healthcare Improvement Scotland. They've been a good addition to being able to keep the message of EIP out there and to have lots of a range of different speakers to come and give us some information and some learning around some of the work that's been going on, not just nationally, but also internationally. My name is Ashley Hose. I am the Senior Improvement Advisor leading on the work for this programme, and I will be here today to chair and to also do some Q&A at the end of the presentation. Next slide, please. So just some basic housekeeping for MS Teams. You're probably all very familiar with it. We do ask that you put some questions in the chat box, so you'll be able to open and close the chat panel, as you can see on the picture there. Your camera and your microphone is automatically switched off. And if you need to leave the meeting at any point, you can, of course, just click on the red button. Next slide, please. This webinar is being recorded and we will share the recording. So if we can ask that nobody else records this session and you can share it wider once we get this up on the web page. Next slide, please. So just a little plug before we get started. As part of this programme, we've been building up to have a commissioned piece, which is a piece of work helping other boards how to set up an EIP service. And as part of this, we've been doing case studies with the 2 Pathfinder sites that we've got in this programme, which is in Dumfries and Galloway and NHS Tayside. And this is the most recent case study that we have. The previous case studies are all on the web page. And I think in the chat box, we're going to get a link to it. But this might be of interest to some people looking at how we've adapted the model of EIP in relation to lack of pharmacy input and time. Dumfries and Galloway have trialled using a clinical pharmacist to bridge some of the gap there. It's quite an interesting read. So the link has just gone in the chat box now there. So if you're interested in looking at that, it's a short piece to look at how they've been using clinical pharmacy. You might be quite interested in reading that one. Next slide, please. So the presentation today is about what will the UK EIP look like in 10 years. And I'm really happy to introduce to you Professor Graham Murray. He's an Honorary Consultant Psychiatrist in the Cambridgeshire EIP service, which is called CAMEO. Professor Murray holds 2 research doctorates, one in cognitive neuroscience and psychiatric brain imaging, and one in cognitive developmental epidemiology. And he also runs a research group investigating the causes and treatments of mental disorder and the neurocognitive mechanisms underpinning psychiatric symptoms, especially in psychosis. So I'm very pleased that Professor Murray could give up some of his time today to talk to us about EIP and where the research is showing this work might be in the next 10 years. Please do ask any questions in the chat box as they arise, but we will cover them at the end of the session once Professor Murray has finished his presentation. So without further ado, over to you, Professor Murray.
Thank you so much. Thank you very much indeed for the invitation, and thanks to everybody for coming to listen. If I start to go over time, please do stop me or give me a warning. but I'll try to keep to time. But just in case I don't, please do shout out if I get carried away. Because right, I will share my slides. Let me make sure I share the right one. Yep, and then I play this one. Okay, hopefully everybody can see that. Do shout out if any problems. Okay, so most people, this is a quote that's attributed to Bill Gates. I don't know if he really did say it, but people often quote him as saying it. And apparently what he said was that most people overestimate what they can achieve in a year, but they really underestimate what they can achieve in 10 years. So with that in mind, I'm going to try and speculate wildly at times as to where we might get to in 10 years, but I'll probably be completely wrong because, you know, hopefully there'll be more advances than we can imagine, but it's a bit of fun and interesting to think about where things could be going. I want to thank at the beginning several people. I mean, there's many people I should thank, but in particular, some people have shared their slides and their thoughts with me. Peter Jones, Rachel Upthgrove, Belinda Lennox, Ben Perry, Emmanuel Osimo, Lizzie Knedler, and others for collaboration over the years, thoughts, but also some of the slides come from them, in particular Peter and Belinda, but also from the others as well. I am gonna, before I launch into how I think things are gonna go in the future, let's revisit a bit of the history and the core ideas and concepts to help kind of anchor us. So there's different ways to think about early intervention, aren't there? One important part is avoiding unacceptable delays in treating established illness, the prompt and proper treatment of psychosis from the start. Those first two are the ones that the English healthcare system has really focused on. As you know, there's sort of the peripsychosis, the at-risk mental state in clinical samples, playing an increasingly important part in the NHS, but certainly hasn't been prioritized as the first two aspects. And then there's ongoing aspirations of you know, what can we do before psychosis, and that hasn't really been a focus in the NHS. So why do we need early intervention? Let's just revisit that and think back to when EIP started in the UK. So of course, I mean, I know that people know this, but it's useful to just rehearse it, I think, before we think about the future. So we know if we don't have it, there's often long delays between symptoms and getting some treatment. We know there can be a very high dropout after first contact with services. At the time when EIP services were being set up, there's a lot of focus on this 3 to 5 year critical period. If you can really get things right from the start, that sets a firm foundation for the future. So that's got a strong sort of face validity to that. Longer DUP being associated with a worse outcome, and so therefore the idea that reducing the duration of untreated psychosis can result in better outcomes. And so this new knowledge was coming in 25 years ago about longer duration of DUP being associated with poor outcomes. And at the time, there was a real mobilization through alignment of people involved, professionals, patients, carers, advocacy groups, lobbyists, and then the NHS plan, all in 2000, all coming through the same thing. And there was other ideas and contexts that magnified and worked together to make stuff happen. Ideas about recovery, ideas about age-appropriate services, a real youth sort of focus at the time. That's changed in England now, but that was a big focus at the time. Ideas of specialisms and specialist services, and there was money available, which of course was very important. And so all these things came together. And then in 2000, there was the NHS plan. I qualified as a doctor in 1999, started psychiatry in 2000. And the NHS plan had a focus on, or one of the areas of focus was on early intervention to reduce the period of untreated psychosis in young people. So there it was at that time, focus on young people, and the establishment of EIP teams across England to provide treatment and support in the community to young people and families, and the ambition by 2004 that everybody presenting with the first episode of psychosis in the NHS would receive the support they need, and it would benefit 7,500 people each year. We now have an incidence of about 10,000. So yeah, incidence has increased since then, population growth, and possibly other factors. So the principles and the ethos of EIP, of course, as you know, the idea was of a standalone multidisciplinary expert services. That standalone service has been the model in the NHS. It's not everywhere. Some interesting developments since then with trials in other countries, in particular the Navigate trial in the US. And there are some parts of England that haven't had at times over the years standalone services, but that was the model. Assertive engagement with small caseloads per care co, focus on reducing that DUP, and having 3 years for everybody, not just discharging people early, and really trying to have that secondary prevention, that prevention of relapse, of being a big focus. The youth focus, and family carer inclusivity, tolerating diagnostic uncertainty, so having a broad net, if you like, to welcome people in rather than what services often do, try to sort of bat everybody away. And so that was in taking us back 25 years. Our service in Cambridgeshire started in 2002. I started working in it in 2004 and still am. So 20 years now for me. What do EIP services achieve? So this was a Cochrane review 3 or 4 years ago, looking at the evidence, the trials. There've actually been more trials than this, but as you know, Cochrane have very strict inclusion criteria and so forth. So there were some trials that didn't make it into this review, but the ones that they looked at, they found that EIP results in more recovery than treatment as usual, fewer disengagements, fewer admissions, suggestion of fewer days in hospital, and maybe fewer deaths as well. So fantastic. And I think it's really important to remember that this is very, very rare in any area of medicine or healthcare to have RCTs at the level of service organisation. And usually managers and commissioners decide some stuff, somebody thinks it's a good idea, and then it happens, and there's no randomization. But we're very privileged to have had RCTs, and those RCTs are the reason that early intervention in psychosis has survived and has had investment, because when people wanted to invest in mental health care, we are the area that has got the evidence to show that if you invest, then you get good results. But things did not go so well. So things were very good for several years, but then of course we had austerity in the UK, didn't we? And all the budgets started being cut. Initially, the budgets were ring-fenced for EIP. So the services, had the money had to be spent. In the English NHS, we then devolved all the power to local commissioners, and there was just money for mental health, and lots of other areas of mental health were struggling. So certainly in Cambridgeshire, our budget started to be cut. It was a very bad time, our 10-year, and I can remember the 10-year anniversary of our team. It was miserable. It should have been this wonderful occasion to celebrate 10 years, but everybody in the trust was having to reapply for their jobs because of budget cuts, and lots of people were leaving, jumping before they got pushed, I suppose. This was nationally happening. So Rethink surveyed all the EIP services and found that half had their budgets cut. So things were not looking very good at that point. But then we were saved, really, by politics. And we got, in 2015, we got direction from NHS England that we were going to have a target. And this is how I learned. This was at this point, I'd been a consultant for nearly 10 years and I'd never met a commissioner. And I didn't really know how budgets worked. And then I learned how budgets worked, or how things worked in the NHS, which is because the government had devolved all the money locally, the government had no control over how the money was spent. But of course, politicians still want to have control. They want to say, oh, local control is very important, but then they still want to have control, don't they? So the government wanted to do something in the area of mental health. This was going back to the coalition government. And in particular, I think the Liberal Democrats were they were very keen on doing something in mental health. There was a lot of talk about parity of esteem between mental and physical health. And we had targets for cancer. We had a 2-week wait time for cancer. We had the A&E wait time. There were no targets in mental health. And so I don't know for sure, but I think what happened was people thought, right, we've got to have a target in mental health. What area of mental health is evidence-based? What is our cancer, something like cancer, where early intervention in cancer is important? What's an evidence-based area of early intervention in mental health? Psychosis. And we had a 2-week wait time for cancer, so we got a 2-week wait time for psychosis. And these targets and these as they were called, access and wait time targets, or Monitor was the organisation, the bit of the NHS that ran these targets. These targets were the important targets at the time, and you got a lot of heat if you missed these targets. So people really paid attention, and we suddenly met all these commissioners once we got a target, and all the commissioners wanted to invest. And I spoke to commissioners and they said, well, nowadays, if you don't have a target, you are there in your commissioning group, and your area, if it's mental health and you don't have a target, and then your colleague sitting next to you is the cancer commissioner and they've got a target, and you're arguing where the money's going to go, it's very difficult to argue that you should get the money if you don't have a target. So once we got a target, then we got investment. And what was the target that we had to meet? We got the most complicated target in all of healthcare, because cancer just had this 2-week target. And so we got the 2-week target, but we also had quality standards. And we had to meet the NICE quality standard, which the quality standards from NICE are operationalized criteria operationalized versions of the NICE guidance. So as you know, the long documents, the NICE guidance, and then these are condensed and sort of operationalized into quality standards. So for us, it's quality standard 80. And I can remember a couple of years before, we'd looked at this in our team away day, and really NICE guidance and quality standards are aspirational care. They're not economically costed in the same way as the technology appraisals from NICE are, but they're really sort of setting out what is really good care. And I remember we looked at it in the WADA, we thought, well, we can aspire to this, but we'll never get there. And then we were told we had to get there, and we were going to be audited on annually on how close we were to getting there. But we would never have done it without investment. And this was the document that laid out these quality standards. So what are the quality standards from NICE QS80 that have been operationalized and that we now have to meet? Cognitive behavioral therapy for psychosis, delivered by quite an expert, well-trained practitioner, family health interventions, physical health assessments and intervention, carer-focused education and support, employment support, and deploying clozapine for treatment resistance. So, I mean, it doesn't seem that difficult, but it's difficult to deliver it on everyone. And you need systems to ensure that people don't get missed. I think, and that's my observation of the challenge, is that each one of these things has been shown to be helpful, but it's very difficult to manage a service in a way that you try to make sure that everybody gets everything. But my experience has been that I think it's been very helpful, actually, it's been a pain to be audited on these things, but because it's a lot of work to document everything, but it has focused our attention on quality improvement and all of I think often targets can be very irritating, but I think, all of these there's not really that much debate. I think everybody thinks these are important areas and we should be working towards them, and by forcing us to focus on these, I think has been a helpful development. So we have this national clinical audit of psychosis in the NHS. We have to record the delivery of these quality of standards, and we have to take part. And it's been a very laborious case note audit. I have spent personally, many hours making sure that in our team this audit works, because, as you know, sort of really finding the documentation in the health record to say, has somebody had, people often in the team might know, the care coordinator will know what the patient has had, but for an auditor to come in and find in the notes evidence of what the patient has, what interventions they have had is not easy. And so each team in England has had to have a random selection of 100 cases, I think, of 100 cases to go through and evidence, what proportion are getting each of these interventions. It's now transitioning to a fully automated system, which will be a great relief to the people who had to go through the individual notes and do the auditing. But that is very challenging as well, to have automated systems that accurately record all of these areas of care. So what's happened during this audit? The reason I'm focusing on this, because I think data is an important part of the future of healthcare. So we'll just say, this is the direction, I think, of how healthcare has gone and is going, of using data to drive up standards. So all the trusts in England with EIP services have taken part in the audit, submitting data on thousands and thousands of case notes, and some reports have been produced over the year. So let's see how we've done over these years. So the timely access, that's the easiest one to measure. It's not as easy as you think to measure, but it is the easiest one. And over the last few years, it hasn't really changed, but I think that's okay. We're not going to get 100% because DNAs are counted in this, and there may be occasions when clinically, it may not be necessary to see somebody in 2 weeks. So performance has been pretty good on that 7, sort of 3/4 or so of people presenting with a suspected first episode of psychosis are seen within 2 weeks by a specialist service. Cognitive behavioral therapy for psychosis has bobbled along at about the same rate over the last few years. The target for this is not a very high. So for each of these different standards, we're given a different target that we have to, percentage target that we have to hit. Family intervention, has not been much progress on. There has been some progress on supported employment and education programs. There's really been very good progress on the physical health screening, and I think that is an area where we're well ahead of other areas of psychiatric care in EIP, getting that right from the start, and then deploying physical health interventions. Getting the interventions is harder than doing the screening, but there's certainly been progress there as well. There's been a big focus in my team to try and make sure you get that done on everybody and record it. If you miss one thing of all the physical health interventions that so let's say you measure people's cholesterol, their weight, their recreational drug use, their alcohol, you do all the interventions, but you forget to document whether they smoke, or you forget if they smoke and you don't do a stop smoking intervention, then you score 0 for all that whole area of physical health. So it's a very challenging target to do, to meet all the measurements and the intervention in 4/5 of your caseload. But it really has focused attention on that. And then education and supported programs for carers. So, and outcome measures. So that having some patient reported outcome measures that has driven up that care. So, the audit has resulted in some areas of improvement over the years, and some areas there was a sort of initial improvement, but it's leveled off. So that's been a look back on the past. So now what about the future? Where are things going to be going? So I think there are a number of areas that I think we in EIP can look forward to some improvements, and some of this is, just analogous to other areas of healthcare and medicine, and some of it is specific to us. So one area where there's a lot of focus in lots of areas of healthcare, is personalized care. That has really been driven forward in some areas, such as oncology. In mental health, we have not had so many improvements in personalizing care in an evidence-based way. We try to personalize care, of course. We have a formulation and we come up with what we think are important interventions for an individual. But by and large, we have a menu of treatments that we sort of offer to everybody, and we don't really know who is going to do well and who is going to do badly. So can we personalize care better? Can we tailor the length of treatment better? We have this model, don't we, of 3 years in EIP. Should it be longer? Should it be shorter? Maybe some people need longer, some people need shorter. What is it, the amount of care you get, or is it the content? So I hope there'll be some improvements in that area over the coming years. We'd all like to see some new interventions, wouldn't we? So I hope we can look forward to some of those. How can we best make use of digital technological advances in our care? Most aspects of life have been revolutionized by improvement, by the internet and by mobile phones, but healthcare famously has been rather slow to change, and it's been rather slow change, and much of what we do has not changed over the years, and we haven't really capitalized on digital advances in the way that other areas of life have. So, you know, I think we'd all like to make some progress capitalizing on that. And can we have earlier intervention? So personalized care, I'm just going to give one or two examples. There's lots of people working on personalized care in mental health. Here's something that came from our service, led by Emmanuel Osimo, who is a clinical lecturer in Cambridge, clinical academic trainee, and he and colleagues developed a risk prediction model for treatment-resistant schizophrenia. As you know, what we do currently is we offer an antipsychotic medicine to nearly everybody, and it works for most people, but not for everyone. And over time, we just observe to see whether it works. We try different medicines, and if they don't work, then after quite some time, sometimes years, we conclude that a person is got an illness that is resistant to our current antipsychotic treatments. And this has resulted in very famously delays in starting clozapine, which is our only treatment that is evidenced to work when none of the other ones do. So can we identify earlier people on a very severe track and potentially offer them either clozapine earlier, or maybe offer them trials if we could work out very quickly that conventional antipsychotics aren't going to work, we wouldn't have to waste years trying many different ones in different combinations and so forth. You know, we could perhaps offer people trials of new treatment, or, as I say, clozapine earlier. So can we work this out right from the start? And so what Emmanuel did was, he didn't do any kind of, so one thing that some people do is do some fancy new assay or test to see if they can work out prognosis. But what Emmanuel did was harness existing data just from databases, electronic health records, and looked at routinely collected information that we have, but that we don't usually use in this particular way, about age, sex, ethnicity, and routine blood tests that we tend to do on every patient: lipids, liver function, cell counts, and then did some computer modeling and developed a model, tested out in different samples, and then found quite a good model. So it's about sort of 70% accurate or so in external sample after calibrating it to the new sample. And that work was published last year, and Emmanuel was trying to improve that. It's not really accurate enough to use, and of course there'd be lots of questions about what you'd actually do with it. But in terms of identifying people early on a difficult trajectory, this is an example of what you can do. And we, together with colleagues in Oxford, are now trying to look to see, can you predict who is going to have relapses right from the start? Which patients are going to have early relapses? Which patients are only going to have one episode? Could that help guide our management as well? And so that work is ongoing, and many groups are trying to work on models a bit like this. Another one I'll just mention is this one on prediction of physical health problems. This is work led by Ben Perry, and this looks at whether you can calculate an adverse physical health outcome, metabolic syndrome. Many of us are familiar with the algorithms that GPs run, the so-called Q risk, to see what is our individual risk of having a heart attack or stroke over the next 10 years. For young people, this is not at the forefront of your mind, but as you enter middle age and one's 50s and up, then certainly start to think about adverse cardiometabolic outcomes as not being something decades in the future, but as something to think about. But for young people, heart attack and stroke are far away predictors, and existing algorithms that predict those outcomes underestimate health problems in young people with psychosis. So Ben Perry developed a bespoke predictor and used a more proximal outcome, metabolic syndrome, as an outcome to predict. And so Ben's model had, again, routinely collected information: age, sex, ethnicity, body mass index, smoking status, whether you're on a good or bad antipsychotic medication for metabolism. And then he had a couple of versions, one with some blood tests, cholesterol and fats, and one without. And this model is pretty good, actually. So the right-hand figure at the bottom right shows you that it's been tested out in quite a few countries now. The accuracy is over 70%, especially if you have the blood tests in it. It's not quite so good if you don't have the blood tests, but they are, routine blood tests, so they're not, anything expensive or esoteric. And Ben is taking that forward to try and get MHRA approval as a class 1 device, and that hopefully will be rolled out and be of use to people. Now, what you do with it, you need trial evidence really to what you can do once you are predicting who's going to do badly. But I've just mentioned that we're supposed to do physical health checks, and we're audited on physical health checks for everybody, and we're audited on doing them. Well, some people have a very, very low risk of adverse physical health outcomes, and other people have a very high risk, but we have to do the same checks on everybody. Now, does that really make sense? Maybe we could, if we could identify the people using a tool such as this who are the most in need, we could offer more regular checks and more interventions, and we could perhaps, save some of our effort with people who, really, if once we work out somebody's at very low risk, we don't have to bother them and use up valuable resource in further checks on them. Okay, so personalised care is a very important part of the UK government's vision for how life sciences and healthcare will go over the coming years, and published this vision for life sciences over the coming years. And the government called this 7 great healthcare challenges: cancer, dementia, mental health, obesity, aging, respiratory diseases, vaccines. So it's great that mental health is in there, and the government is keen to get investment from the private sector. And I mean, one reason for that is because there's not much scope for investment in the public sector because of the state of the economy. So if we can get investment from industry, then that will be good for the economy, and hopefully it should be good for patients as well. So the government's vision is to have harnessing the private sector, academia, NHS to drive forward progress and economic growth as well. And there's a lot of focus in this life sciences vision on technologies, omics, digital technologies to drive data, to drive improvements. And as part of this life sciences vision, there has been investment in mental health research capacity. So last year, over £40 million was invested by the Office of Life Sciences and National Institute for Health Research, which is a UK-wide investment, actually, by the way. It's not just an English investment, as this mental health mission to develop innovative new treatments and technologies and make the UK a really attractive location for industry to invest and offer new treatments for research. And this mission is being sort of rolled out by the Translational Research Collaboration, which is a network of the English biomedical research centres. So biomedical research centres are collaborations between universities and healthcare trusts about translating research, translational research, not discovery, sort of very basic science, but translational research. And there's a network, and we've had this network for a few years in terms of the translational research collaboration, and it was quite good. We had, so there's these English biomedical research centres, and then there's also input from devolved nations. And we used to have meetings often in London, and then in the pandemic, they would be by video. And there was good ways of networking, but there was no money. But then suddenly there was this network and there was money as well. So this translational research collaboration has been sort of commissioned to deliver this mental health mission. So there are the areas of focus of this research capacity investment are mood disorders, and early psychosis is one of the priorities of interest to us. There's also informatics focus, children and young people's health focus, training and capacity development, and some omics and input from the NIHR bioresource. Okay, so myself and James Walters from Cardiff are leading the work of the early psychosis workstream, and I'll just tell you a little bit about that because I think it hopefully highlights some of the areas where we will see some progress in years to come. So we were guided really towards these broad aims of exploiting advances in omics and digital phenotyping for more personalized treatment, and also hopefully making it easier to recruit and conduct large-scale studies, but not missing out underserved communities to drive forward new developments and new treatments. So in our work, there's a big package of work about digital phenotyping and a digital registry, and that's being led by UCL in Birmingham, James Cuttbride and Rachel Upthegrove. There's work towards implementing a national detection system for people at risk of psychosis, Paolo Fusapoli and Sarah Sullivan, and then omics work for personalization. The digital registry and phenotyping is something that we hope will help in clinical care, not just in research. We want to be able to support rapid stratified patient recruitment for trials, but also provide safer and more efficient clinical management and help evaluate some of the real world effectiveness of interventions. So this part of the project we've called EPICare. We had some initial funding from a program development grant, then to do some of the early scoping work, lots of engagement with IT and stakeholders, patient and staff input into this. We currently have investment from the Mental Health Mission to build, pilot and refine this registry and clinical decision support system. We've just had news that we have been funded to evaluate the effectiveness of it, and then we'll have a national rollout of it, we hope. And so this really ties in. Here what we're trying to do is, over several trusts, capitalize on the information that is routinely collected. For example, we all have to record this information for the NCAP audit. So can we pull that data together? And then at the moment, that information is just really pooled for audit purposes. But can we develop algorithms and processes to help remind clinicians and keep track, dashboards, to know, okay, so it's very difficult job to try and know who on your caseload has had all of these different interventions and have systems to make sure you don't forget to offer things to certain people. So we want to really capitalize on digital to make that easier for clinicians to have reminders of what to offer, and then also some personalization as to what might work for some people, the right intervention at the right time. So we hope this will improve clinical decision making, but also be a very important research resource as well, for using anonymized records to drive forward research. And we've got currently Birmingham, Notts, our service in Cambridgeshire, a London trust, and hopefully, Manchester, and then hopefully also Oxford and SLAM involved as well. But we are looking for other services to get on board with this. And I think once it starts to be rolled out and starts working, then hopefully it will be easier for other trusts to come on board if they find it's helpful. In another work package, we're trying to implement a national detection system for people at clinical high risk of psychosis. It is not easy to identify people at high clinical risk of psychosis. There aren't many trials in this area. It's difficult to get people into trials. I know there's some important work already going on in Scotland, collaboration between Glasgow and King's in terms of digital detection tools, the Enter detection tool. King's have got another one called Detect, which screens sort of secondary care records automatically from CMHTs and the wards to try and identify people at high clinical risk. P-Risk is one from Bristol that screens GP records to try and highlight people who are at high risk of psychosis. So we're hoping to scale up these existing algorithms to make sure people don't get missed, and then invite them into studies to drive forward care. And then we're trying to do a big cohort study of at least 2,000 cases over the next few years. So recruiting 2,000 people with early psychosis to try and generate a resource that can facilitate discovery research, help stratification in trials, be a point where we could raise investment for other omics to see if fancy omics assays could be of clinical use. And we're just finalizing the protocol on this, and this will be open not just to English sites but to devolved nations as well. So hoping to recruit from some patients in Scotland for this. Some people might be a bit sort of suspicious, or skeptical that genomics or omics will ever deliver some improvements in healthcare, and I understand that. It is a real focus of the government, though. I mean, this is Our Future Health. If you haven't seen it, there are 5 million people being genotyped as part of Our Future Health. It's getting on for, working towards just under a tenth of the population. So you might think it's fanciful to think that one day everybody will be genotyped, but I think the direction of things going with how cheap it is, and how much it's getting cheaper, and how much progress is being made of other areas of healthcare about stratification by genetics, I think this is happening, and we don't want to miss out on it, even if it's just side effects, profiling or physical health. Then I think it's important for mental health to be in there and having and not being left behind really on this. So we've got some omics work. We also are offering a mobile phone app to patients to fill in their symptoms. We're using the Care Loop app, which is which patients can self-report psychotic symptoms and mood symptoms on. We went for Care Loop because it's one that has the best research record really in psychosis. There have been randomized controlled trials to show that this app, which asks questions that are adapted from the PANS, so self-report, it's about 70% accurate. A patient doing the self-report on the app compared to a gold standard clinician interview, and in RCTs it's been shown to be helpful. I know that in Glasgow you've been using a sort of building on this app with the Empower study as well, so that's the same sort of underlying technology in the same digital team or a related digital team. So I think there's a good track record of this and integrating it with health services and evidence-based. And so we hope that this will be useful to people, but also provide a rich set of data for research as well. And hopefully in the future, this may be something that is rolled out clinically to benefit patients and make life easier for staff. Another thing I think that, so in our study in the Epicare sites, everyone will be asked to use this app, and then in the people in consent to research, there'll be additional sort of research modules that people can complete, or more frequent research questions. And then in the non-Epicare sites, again, people will be offered the app that they can use and complete for research purposes. In the non-Epicare sites, it won't integrate with the healthcare records because we don't have enough budget to integrate it to the healthcare records across the whole of the UK, but it can work either integrated or non-integrated. Another area I think where I hope there will be some improvements in clinical practice is the use of NLP. So this is the sort of leading NLP group in healthcare, mental health care, but SLAM, but there's excellent work going on in Cambridge and elsewhere, Manchester. The argument really for using NLP is that we already put a whole load of information, don't we, into the case notes, often in free text. There's lots of really rich information in there, but it's hard to use that because it's unstructured. So it's hard to use that for managers. It's hard to use that for clinicians in a way without trawling through. But there are developments there. And so, for example, in London, they're working on ways to develop CROMs, so clinician-reported outcome measures, which, as you know, we're often asked to do. Sometimes we want to do them. Sometimes we're told we have to do them, but they're hard work sometimes to do. And but can we have sort of virtual CROMs that are scraped from the health record so that when you type your mental state exam, could you calculate a PANS? Could the computer calculate a PANS, estimated PANS score, just from stuff that you're already typing in? And that could be used to track progress over time, could be used to feed back to an individual on how their progress is, could be used to highlight if somebody might be eligible for a new study, for a psychotherapy or for a new medicine, and so forth. So I think there are definite developments in this space. It's been very useful for research, national language processing, but it's getting to the point where I think I'm going to predict in the next few years it will be available clinically in terms of these sort of virtual CROMs, which will save work and save burden on clinicians. What about new treatments? Here's a meta-analysis of chatbot-delivered psychotherapy for mild mental disorder, showing that chatbot psychotherapy can be helpful. You know, there's lots of investment in this space, mainly in the kind of depression, anxiety area. But if you haven't come across it, this is kind of WhatsApp style delivered psychotherapy. There's lots of organization delivering therapy, a therapist with a therapy with a psychotherapist at the other end of the WhatsApp style chat, and that's been shown to be effective. And then, of course, the organizations that are delivering this WhatsApp style chats with real therapists have a huge amount of data to train sort of chat GPT style models of what a chatbot psychotherapist would do in a given situation based on what a real therapist would do in a given situation. And I think this is coming for mild mental disorder. So, you know, why not I think this will play some role in psychosis treatment as well. I mean, there will definitely still be a role, if there's anywhere in medicine that there'll still be a role for face-to-face care and engagement with humans, it's psychosis. But I think, you know, it would be foolish to think that, you know, we can't. There'll be some patients in EIP services who will want this and who will benefit from it. So I hope there'll be some developments in this area. It looks like we might have a new medicine. CAR-XT, this was published last week in the Lancet. This could be the first non-dopamine D2 receptor antagonist that's effective in treating psychosis. This is a phase 3 trial. The drug, if you haven't come across it, is a muscarinic agonist drug. There's been research on muscarinic agonists for quite some time. Clozapine has muscarinic agonism. And some people think that its actions are, you know, why it's so good is because of this. But they're rather unpleasant side effects, muscarinic agonists, especially gut problems, diarrhea and so forth. As you know, anticholinergic medicines can make you constipated, but agonism can give you diarrhea and a tummy upset. So that's sort of what previously hampered these muscarinic agonists. The muscarinic receptor is the one that acetylcholine works on. So yeah, that's really hampered the development of this. But so this drug company had the idea of having an agonist that crosses the blood-brain barrier and activates the receptors that you want to in the brain, and then an antagonist that doesn't go through the blood-brain barrier, but prevents you getting diarrhea by blocking the receptors in your gut and so forth. And it does seem to be very effective. So these are the results in the Lancet paper, with benefits on PANSS total, positive symptoms, negative symptoms. The blue line is the medicine showing improvements week on week, and the red line is the placebo. The patients in this trial were not taking any antipsychotic medicine or any psychotropic medicines other than benzos. They were allowed to have, both groups were allowed to use benzos because it would be very difficult to treat people with, these were inpatients, you know, with no medication at all. But yeah, it really does look like it's going to be effective. We'll get results of another phase 3 study soon, but I hope that we'll be able to offer this new treatment and, you know, something different in the next few years. How are we going to get more new treatments like this? So NHS DigiTrial is a development. A barrier to research is we don't get enough patients into trials in psychiatry. We have much less uptake of trials in mental health than in other areas of healthcare, such as cancer. How can we get better uptake? Well, one development is DigiTrials, which is NHS England using the data it holds to directly invite patients into trials. So they're piloting this with a few areas. This is going to be big studies that are recruiting thousands of patients. And rather than the traditional method, which is to send out messages to researchers and clinicians and then rely on us to invite the patients, and we often forget to, or we're too busy to, or we don't want to bother people, NHS England is planning to send text messages to select patients to invite them to take part in research if they want to. And as NHS England knows all the NHS numbers of all the new cases, because we have the NCAP audit in the UK, then this presents an opportunity for us to directly invite people with psychosis into trials if they want to. You can opt out of this. And another development, so I hope this will, we will get some increased trial and be able to offer people the opportunity to take part in trials. And another development is the first UK, or the first platform trial of medicines for psychosis. So PUMA is the early psychosis multi-arm, multi-stage platform trial. What's a platform trial? A platform trial is, you might have come across, or many of you will have come across the recovery trial in COVID, where several treatments were trialed all at the same time. Rather than a traditional trial where you just have one intervention and one placebo, and you have huge amounts of work to set up the thing, in a multi-arm platform trial, you have several treatments being tested at once with one control. As soon as you realize that one medicine or other intervention is not effective, it gets kicked out, another one gets brought in, there's a committee to decide which medicines or other interventions are brought in. You don't know at the start what all the treatments you're going to try are, but you have procedures to identify those. And these platform studies can allow much more rapid progress than the traditional design, and they're very popular, or they're increasingly popular and in other areas of healthcare. Been very helpful in prostate cancer. There's been a very effective one, and lots of neurological disorders are setting them up now. And so Wellcome Trust has funded the setup, led by Belinda Lennox from Oxford, to have this setup of establishing this investment to set up a trial platform co-created by the whole early psychosis community in the UK, patients, carers, clinicians, academics and regulators, with the aim that we will have our sort of equivalent of the recovery study that they had for COVID, that had those rapid treatments identified for COVID, rather than waiting years and years for new treatments to come through. We'll be able to test treatments quickly and hopefully get some new treatments through. They're going to start with medicines because they're easier, but then then other interventions could be in scope. But there's no money to there's money to set it up, and if the setup goes well, then it will hopefully gain further investment and be rolled out. So I'm coming to the end of my time. I want to just say that I think the principles and ethos of EI that we started talking about, I think those will continue. I really hope and I anticipate that EIP will continue as an exemplar of how research and clinical practice will work together for better outcomes. And the reason that we have EIP and why it has been so successful is because of the research. That is the reason that we have had investment and other areas have not. So I think that is absolutely vital that we continue to be constant. We should do this in all of healthcare, of course, anyway. We should be doing research, evaluating what's effective, stopping what's ineffective, making improvements, having innovation and so forth. But EIP has been a really important exemplar of how that can be done and how that can lead to better outcomes. There's going to be an increased role for digital health, and it's really important we engage with that to make sure it makes life easier for patients and staff, because sometimes innovations in digital health makes life more annoying and more difficult for patients. I'm sure, anybody, we've all struggled with electronic health records, and you think, who is this making life easier for? Because it doesn't seem to be making my life any easier. But I think it's important that we engage and get the good technological innovations that make life easier, as your phone makes life easier for you in many ways. I think we need to capitalize on bigger nationally coordinated research efforts to get new treatments, whether they're medicine, psychosocial, digital. I haven't talked about new there are some really interesting new psychotherapies coming through, avatars and VR-based ones, but it's not my area of specialism, so I haven't talked about those, but I hope we will see some psychological interventions coming through as well. But we've got to really capitalize on national coordination and not be competing against each other, I think, but coordinating to deliver really definitive answers and know what's effective and what's not effective. And I hope we will have more personalized care, making use of this, really rich data that we collect, potentially some new data, or maybe if there's some fancy omics measures that can be useful. But there's a lot we could do, just with existing data that we type in to the electronic health record that could be helpful, and with simple blood tests that we're already doing. So I'm going to thank you very much for as many people who've contributed to this work over the years, patients, clinicians, collaborators. Thanks to them, and thank you for your attention.
Thank you so much, Graham. That was absolutely brilliant. Really fascinating, and could have actually listened to you for a lot longer, because so much of that is really pertinent to what we're trying to do in Scotland. And it was really good to hear some of the links. And I mean, EIP is a priority area in the mental health and wellbeing strategy for Scottish Government. How we deliver that is still being debated, but we do have our Pathfinder sites in Scotland who've been showing some really good results, which is why we're still in the position where we are of having EIP high on the agenda. There is a couple of questions, so I'm just going to run through them, Graham, for you. First one, there's a couple on the data. So from the data that you showed, are the targets and the stats relating to people being offered an intervention, or do they have to take it up for it to count?
Yep. So it's different for different ones. So in our audit for CBT, that it has to happen. It's not good enough. We don't get points if we just offer it. For the physical health interventions, we have to offer them. And if somebody makes an informed decision to decline it, then that is we're okay. I think we have to offer it twice. And it's not just offer it once and then. So we have to offer it twice, and then if we have to document that you've offered it, and then you have to document that the person has declined it. And that was not too bad it's still effort to document all of that. It's particularly difficult electronically to document that with the sort of these SNOMED codes that we're now told to use, these special IT codes for every intervention. Now, there's IT codes for interventions, but it's quite difficult to code the fact that you have offered and an intervention has declined. That requires 3 codes, I think. We've been battling with that in our IT system, because now we're told we have to do everything by SNOMED. So we have to code the intervention. Then I think we have to code that there's some kind of qualifier to this, and then there's another code to say it's been declined. So you need 3 codes to basically say the patient does not want a stop smoking intervention. So it depends on the different ones. Some of them, the target is sort of set quite low to, but refusals sort of count against services in terms of the quality assurance, and then others, the target, like physical health, is set very high, but you are allowed to have declines.
That's interesting, because we are monitoring in our Pathfinder sites the fidelity to the model, and it's kind of paper-based right now, but it's looking at who's been offered it and who's declined it, and what that kind of looks like, and who's ready for that kind of treatment. So we're trying to do something similar. We just don't have an electronic way of doing that yet.
No, well, I mean, there is definitely this move to having it electronic is, much more advanced, as you can imagine, in some trusts than others. And for years, right from the start, the ambition of the NHS England was that it was to be electronic. But all kinds of things happen. So I can remember being in a meeting with people from NHS Digital, and they said, oh, well, you know, all the trusts should be able to do this because all the major kind of electronic health records software can do these SNOMED codes. But in my trust, we had got a version of Rio at the time. We don't use Rio, but our version of Rio could do SNOMED codes, but we bought a version that couldn't do it, I think. So, and I don't think that was appreciated actually by the people who set up the stand. They sort of thought, oh, Rio, that should be fine. But you know, there are different, so there are lots of intricacies, and now we've moved to System 1. And, you know, it's easier in some than in others. And of course, you make progress in one, and then for whatever reason, trust hierarchy decide to switch you to another one. So it's challenging.
Yeah, it is. It always is, I think, with these electronic records and how you do that and keeping continuity across the boards. The other question in the data was, is the CBT down to lack of qualified staff to offer it, or is there not enough engagement?
Yeah. Okay. So the CBT standard is challenging because I think the committee that came up with the standard actually, which was drawn from the trials. So in the trials, I think the CBT tended to be delivered by people who had a master's, who had a master's in CBT for psychosis. And so that was basically I think the standard that was required for us to hit. So you could be quite an experienced CBT therapist, but if you don't have that master's level qualification, then the work you're doing does not count for this audit. So NHS England did make available funds for these master's courses and for training people up. And so doctoral degree counts, a clinical psychology doctorate counts, but what we have done in our service and in many services, we've taken band 6s who might be nurses or OTs, and then they have won funding to go on these master's courses, and they've continued their work part-time in the team, and then they go on a master's course to train to become a CBT therapist, CBT for psychosis therapist, and they do that alongside their work. And once they're qualified, then they're fully able to offer the care. And I think that's been very good. That has enabled. So it's a stringent standard, that one. For the family therapy intervention, the requirement is much less onerous. But you can imagine you can't just train up a master's level therapist overnight. So that is that's been an issue about workforce capacity. But of course, it's not always I think we should be offering CBT for psychosis to everyone, and I think it's good that we have that we're told that we should offer it to everybody. It's not appropriate all the time. There are some situations when you just cannot even contemplate that, and so you're never going to get 100%, because there are some situations when you really need to sort something else out first, and maybe the time isn't right. But I think the danger there is you can forget. You sort of think, okay, there's so many crises going on right now, we need to focus on this, housing, and so forth, or family therapy is maybe indicated first. I've got a patient at the moment that I've just been discussing with my colleagues. Should we be offering, we should offer CBT for psychosis, but really we want to do a bit of family therapy first. And that's fine, but you don't want to forget the CBT for psychosis. So I think in that way it does help to have the target.
Yeah, that's an interesting one. The next question I've got is on medication, and this has come up a few times, and it's about the high rate of prescription of clozapine that some patients might be started on, and then looking later when they're discharged from the team, I guess, where some of these patients are going, and concerns around if they're going back to the GP, is the GP monitoring this? Should they be monitoring it? Should they be going back into the mental health services? What I would say before you answer that, though, is that the discharge pathways as part of the EIP teams that we've got is looking at exactly that. So what's the different routes of discharge that this person might have, because that's going to be very person dependent, what medications they might be on, and whether they go back into the community mental health teams, which is what we've got, or whether that would sit with a GP. So just any thoughts you had on that.
Yeah, okay. So it's a very interesting question about discharge. So in my service, we discharge something like 70–80%. I think that's quite common. 70 or 80% are discharged to primary care. I mean, it may differ, of course. There may be some settings, urban, rural, etc., different ethnicities where it may vary. Funding, will make a difference. Belinda Lennox and colleagues, a number of people have looked at discharge destinations. Now, of those 80% who are discharged to the GP, the majority do not relapse in terms of a readmission or use of crisis team in the next few years. So that's fantastic. It's really good news that you can discharge the majority of patients, and of the patients you discharge, the majority don't need to come back into secondary care. I mean, there will be a few who are probably unwell and getting no services, but the majority are doing well and managing well in primary care, which is fantastic. Of course, the ones who are discharged to secondary care, many more of them do relapse, because the reason you're referring them to secondary care is because these are your sickest folk. But I think at the moment we could have more science in who are we, why do we treat people for a certain amount of time? Are there some people who, if you're going to do really well in primary care, do you need the full 3 years? Is that essential for you to do well in primary care? For some people, maybe it could be less. And then there are these other people who really are on a very, very severe illness course, the people who end up with multiple admissions, spending a long time in hospital, and they need, a very different kind of pathway of care. And so I hope that we've got a bit of a one size fits all at the moment, but I think we could do better in sort of stratifying people onto, good track, and, really right from the start thinking this person is going to have a very, very difficult course. What can we do early to improve their course and put them on a better trajectory? For clozapine, one good thing about clozapine, I think, is that you can't discharge to primary care because GPs can't prescribe it. So you have to be in secondary care, and you get lots of monitoring. So I think, because you have to have all the blood tests, which in a way are a hassle, but on the other hand, it does mean you get lots of regular reviews and you get your physical health monitored closely. And I think that is, probably one of the beneficial aspects of being on clozapine, is that you can't just get discharged and you can't just be I'll see you in a year, because you have to come back for all these monitorings. So you just get more, you get better and more care if you're on clozapine. I mean, of course, there's lots of problems, but it does necessitate a certain level of input that you don't get if you're on a depot.
Yeah, that's interesting. And exactly what we're looking at as part of the discharge planning for those individuals. Question on treatment. You've used the phrase offer treatments a number of times. Do you envisage more choice for patients in the future, consistent with proposed changes to the mental health legislation, which I think you've sort of covered a bit?
Yeah, I mean, I definitely think we should be having more choice. I think I mean, in terms of medicines, you can offer a choice, but they're basically all the same, aren't they? Apart from side effects, right? So it's not that much of a choice. I mean, so I think it would be really good if we could have some really, a more diversity of choice in terms of medicines. I think if we also can really work towards ways to help people make those decisions in terms of, okay, whether it's with the medicines that we've got at the moment, and we might say, okay, there's olanzapine, which of course in inpatients is very popular, or inpatient consultants, I should say, is very popular because it works well. The side effects you don't get straight away, apart from sedation, which is quite useful when people are very agitated. And but the problems come later, where it's no good to be sedated if you want to go back to work or education, and then by then people are starting to gain weight and so on. So are there ways that we can provide better information about an individual's risk? Because not everybody gains weight on olanzapine, and if you don't gain weight and it doesn't affect you metabolically, then it's a fantastic medicine. So can we identify the people who aren't going to gain weight on it? And then that's a brilliant medicine to offer. And then if you are going to gain a lot of weight and be at risk of metabolic syndrome and ultimately diabetes, stroke and heart attack, give that information to people and enable people to make an informed decision about it. And hopefully, maybe there's some of these there may be some new there's new medicines. There's the weight loss, the famous weight loss jabs, the GLP-1 agonists that are going to come in. I'm sure they will play a role in mental health, about preventing some weight gain. Metformin we can use already. But yeah, definitely agree in terms of offering between biological treatments, and then of course, having more psychosocial treatments to offer as well, and being able to offer things to people, but informed by hopefully some evidence as to, we think this is probably going to work better for you. This one you might run into some problems with, but we're not sure. We can't know for certain, and find ways. We'll have to do a lot of work on how to communicate these things.
Yeah, and that's interesting. That I think the next comment was kind of linked to that, saying that somebody speaking to GP colleagues about their physical health monitoring for antipsychotic treatment. They think we're doing it, we think they're doing it. So there's a kind of that big shortfall in the patient's life health outcomes. So that's certainly something that we've been embedding into the service that we've been looking at in piloting it.
And that, those things are tractable, right? So there are some things that are extremely ambitious, like new medicines, new psychotherapies. These are hard, right? But hopefully we'll have them. But just making sure that everybody who needs it gets their cholesterol checked, and it should be, it's really an engineering problem, isn't it? And healthcare engineering and organization. So we hope that, technological, and can we get the data working for us to flag up, who can we have dashboards? So that is what we're trying to do with Epicare, and what trusts are trying to do with NCAP as well, is can we have dashboards that say, look, this patient has not been offered a stop smoking intervention or a cholesterol check. Make sure you offer it. If the person declines it, fair enough, but don't just forget about it because you think the GP is going to do it and the GP thinks the team's going to do it. Yeah,
absolutely. How can future planning for EIP address current ethnic disparities in care?
That's a really good question. So one of the things that is just coming through, and again, I think this is where data is helpful. I think now because we're collecting data on offering, for example, psychosocial interventions through NCAP, one can then look and see, well, which which trusts are offering the CBT for psychosis and which trusts aren't. So somebody asked about that earlier, actually. I should have said those were national averages, but some trusts are brilliant and other trusts are hardly offering it at all. Presumably the ones who aren't offering at all don't have the qualified staff to offer it, but maybe there are likely biases, and I think there is some initial evidence that is coming through to show there are biases. And you can imagine the sort of people who tend to be offered the psychosocial or the psychological interventions and test the hypothesis that is it related to social class and ethnicity and so forth. And so we can have data on that now. And I think some initial data is coming. Well, yeah, it is coming through to be able to look at that. And once you've got that, then and we hope that by developing these decision support tools that remind, look, you haven't offered CBT for psychosis, please offer it, then that will overcome some of these biases that one thinks, oh, I think I'll offer it to this person, I won't offer it to that person, that, you know, for a whole host of reasons that might operate. So I think there's hopefully some leveling up that can occur you know, in relation to that, and drive equality upwards.
Absolutely. Graham, thank you so much. I know we've only got a couple of minutes left. There's been other questions in the box which you haven't got around to, so we'll have a look at them and see if we can perhaps get them answered, because there's a lot of, you've obviously highlighted a lot for that's got people thinking. So thank you so much for all that. There's a lot for us to take away and think about as well for what we're currently doing in Scotland and how we kind of continue to move this forward and build more EIP services as we go. I think we have a poll to put on have we got a poll? Oh, here we go. It's just a very quick 1 or 2 questions. You can go through the screen, everybody, just to give us some feedback on the actual webinar itself, just if there's anything we can do slightly differently. So you can flick through that yourself and pop your answers on there. Close that one down, and that should be able to, there we go. You can start to see them down the chat box. Great. So thank you everybody for coming and engaging in the chat today. We do have, you can use the QR code to take you straight to our website, which is where we have updated reports from the work we've been doing, the case studies that I mentioned earlier, and we will be having the phase 2 of this work will be finishing up in March, so we'll have reports coming out for that as well. But if you want to be added to our mailing list, there's an email address there as well, so you can keep up to speed with everything there. We will be having more webinars coming up in the next couple of months, so we will keep you on the mailing list for that and you can join into them. So thanks everyone for coming along and giving up your time and for putting questions in the chat box for Professor Murray. And Professor Murray, thank you so much again. That was really, really interesting, and yeah, we hope to keep in touch and maybe get you back on again.
Pleasure. Thanks so much for having me.
Grand. Thank you so much. Bye, everyone.